Good afternoon, everybody, and welcome to the Independent Scientific Advocacy Group public meeting. The Independent Scientific Advocacy Group is a collection of scientists, public health doctors, epidemiologists, and others who are advocating for an evidence-based approach to pandemic management. Today, the topic that we are going to focus on is long COVID, which is the long-term lingering effects, post-infection syndrome that many people have experienced. But we're also going to talk more broadly about the situation in Ireland. And as usual, we are very, very happy to take questions from participants. And if there are any journalists in the audience who would like to have their camera turned on for their question, we're happy to do that too. So just a quick mention that one of our speakers for today, unfortunately, was not able to make it. That's Claire Toomey, who is founder of COVID Cases Ireland, which is an online community and advocacy group for people suffering with long COVID. Unfortunately, she wasn't able to make it today, but we do have other people who can talk about their own personal experience of long COVID in part of the discussion today. But as usual, to start off, we are going to look at the situation in Ireland, and James Merrick is going to give us the latest in terms of the data. Thank you, James.
Thank you, Eva. Agus Eva Cardia. So the kind of synopsis of the next few slides that I'm going to show is compared to the last couple of weeks, Northern Ireland is pretty stable, and in the Republic, the sort of bounce in cases in children and teenagers that we were concerned about following the reopening of schools after Easter is starting to show up in the data. So that's the summary, and we'll go into a few details now. If we could bring up the slides, please, Ben. Yeah, so thank you, Ben. And we'll just start with the previous slide, please, Ben. Yeah. Yeah, and so thanks to Paul and collaborators for all the work in the background that enables this rolling analysis. So this is Northern Ireland. This week we actually are showing a linear scale with the and the x on the y-axis, and on the x-axis we're from the March 1st up to the last few days. And so in the north, the black line is the different color lines are different age groups. The black line is the population average and daily average cases per 100,000, and so we see this element of, we mentioned before, a little bump around Easter, probably a drop in testing, and a general slow decline across the population, and with lower viral incidence rates in older age groups, more vaccinations there. There has been an increase in children also in the north. Now, there was different testing criteria before. There is increased testing of children around schools, so we'll be keeping an eye on that. But just on the lower lines there of over 65s, they have been a while now vaccinated in Northern Ireland, and there's still virus around in that age group. Go to the next slide, please, Ben. I'll continue on that theme. Thank you, Ben. Yeah, so the blue line here is healthcare workers in the Republic, and again we see this steady decline. Group with greater than 90% vaccination rates within the group, but there are still some cases being identified in that group, which kind of gives that overall idea of that a theme you're going to hear in our ISAG discussions about vaccination. Very helpful. You can see it there in the difference between these two lines, but it does take time. And is in conjunction with other public health measures. And the yellow line is public health, the yellow-orange line is public health, non-healthcare workers. And we had this trend where coming up to Easter, we saw this increase in the population. Then coming into Easter, we saw this decrease. And then we've popped up in the last week again, this increase in the yellow-orange line since last week. And the next, and I can say it now, it's largely driven by young people, and the next few slides are breaking it out by age. And so this is older age groups. I'm going to go pretty quickly through the older age groups, but there's something. The green line is 85 and over. There's something a little disjointed here but it could be just noise at low levels. So, relatively stable in the older age groups in the Republic. If we could go to the next slide, please, Ben. Yeah, and again, in the middle, 25 to 64, we see maybe a slight uptick in the younger age groups in that band. But if we go to the next slide, we'll see the big jump in cases coming in 15 to 24-year-olds is the green line here, and also primary school age children 5 to 14. While there hasn't been the same uptake in kind of creche going children this time, but the thing we've said, and I feel like a broken record a little bit on this point about schools. We know how the virus can spread in poorly ventilated indoor spaces, and we have evidence after evidence after evidence of that. We know there's increased susceptibility of children to B117, and you put those two together, and there are just very few mitigation measures in school for airborne transmission, and we're now seeing sadly predicted increase in cases in this age group. Now, I'm sure there's, of course, all these things, there are many causes, but the data is showing what we were worried about. I'm from East Offaly myself, and there's been a lot of outbreaks in schools, and it gets personal then when you know the households and families involved. East Offaly and Kildare in the last couple of days. And the economic. The last thing I'll say on this point is the economics of this. I still can't understand, because the cost of this spreading. I'll just stick in the previous slide for a moment. Then the cost of this. The long-term cost of all these children getting infected, we don't know about, and also the virus spreading in the community. So there's a lot of costs there. On the other side, we know there's a lot of costs with no education, no in-school education. So the middle ground of investing in measures that we've talked about on the previous ISAG webinars to reduce risks of in-school transmission just make a lot of economic sense, but for whatever reason haven't been done to the extent they could have been done. And sadly, we're seeing it in the data again. Last slide then, please, Ben. Just final word on some global context. When I look internationally, there's quite a different world out there. High vaccination rates in certain countries, USA, Britain, Israel, we hear a lot about. But it's important to know that there's still a lot of restrictions in those countries, and say in Israel, schools were fully reopened, and very high rates of vaccination in the population. Then there's terrible images coming out of India, still coming out of Brazil in the past week. Of COVID running through the population, and still in the EU, like deaths are still rising across the EU. On the positive side, then, and probably the vaccines are really getting in the Republic. It should be acknowledged that in the past week, there's been numerous days in the past week where the record was broken for daily doses administered, and probably we all know people vaccinated in the past few days and getting vaccinated the next few days. So that's positive, and I think it's pretty relevant to the topic of today's talk. We're still a few months away from all adults being vaccinated, further away for children being vaccinated. So what are we going to do in the meantime, and what are the implications of different choices? So thank you.
Thank you, James. I think everybody will be quite alarmed to see those graphs going the wrong direction once again, especially when everybody's in the mood for more relaxation of restrictions, and that's the message that's coming through, filtering through from government comments, is they're talking about opening things, and they have always said it's the data, not the dates, and the data are really not suggesting there's any scope, unfortunately, at the moment for relaxation. In terms of what you see there, James, so you've shown very clearly the increase in the school-going age. Is there any suggestion yet, or do we expect any indication in the data that then these individuals are bringing it home and it's passing to their parents or other family members?
Yeah, it's probably, with the cycles involved, it's probably a little early to say, but you do see this uptake in sort of parents' ages also. Now, there are multiple things going on, but unfortunately, like given the structural reality of children living with parents and the nature of a home environment, it's probably inevitable. That's the next step. Yeah.
Yeah, and it's the case with B117, isn't it, that the home, the infection rate in the home has been really, really high, higher than with the previous one. Is that correct?
Yeah, absolutely. And so it feels like with these cases in children rising, that there's a certain amount baked in now that we're of the parents' generation and a minder's generation, which could be older again.
So that doesn't look good, unfortunately. I think that's quite worrying, actually, to see that after we've had it's been incremental recently, but it was looking better for a while, and to see it plainly going the wrong direction again, I think is going to be very worrying for a lot of people. Thank you very much, James. I think it's very important to have that update and that information. And so on to other speakers. So our first speaker today is Dr. Andrew Kunzmann, who is an epidemiologist in, I'm going to get this wrong, it's not in Queens, is it? Is it Queens? Yeah. Oh, great. Yeah. Okay, sorry. Whoops, sorry. Sorry about that, Andrew. And Andrew is going to address today's topic of long COVID and looking at that from population health and epidemiological point of view. Thank you, Andrew.
So thanks, Aoife, and good afternoon, everyone. I'm just going to talk about the scientific side of the long COVID evidence. I'd hoped that we would have Claire introducing it from a personal perspective to kind of give the depth and actual experiences of this before launching into any description of the evidence or anything, because I think it's always important to hear from patients first. But hopefully Chris will be able to give us a description of this after, to add to my boring scientific definition of long COVID. So first slide, or second slide, please, Ben. So just to give a bit of a description for people who are unfamiliar with it, long COVID is a name decided by people living with it, and I think that's the importance of why we don't use a more boring scientific definition. And it's basically the signs and symptoms that continue or develop more than 4 weeks after the initial illness, whereas post-COVID syndrome is a more official diagnosis for symptoms that continue for more than 12 weeks that aren't explained by an alternative diagnosis. But that will often mean that many people are missed because, unfortunately, due to the testing regime, not everybody that's been infected and not everyone that's continued to suffer long-term consequences was able to receive a test and receive a confirmation of their diagnosis, which will pose challenges for the health service going forward in getting recognition for people who are living with this condition. And the symptoms are quite varied, and it may in fact be different syndromes rather than one consistent syndrome. But essentially its symptoms can include fatigue, headaches, brain fog, and a range of other conditions that range from fairly mild symptoms to fairly substantial clinical diagnosis. And I'll go into a bit more detail in that next. Next slide, please. So there was a bit of confusion around long COVID earlier on, and I think it's only recently that we've been able to get higher quality studies. So for a long time, I think there's been a range of emotions from quite scary high figures of the prevalence of long COVID to fairly what could be classed as denial of the condition. And I think that hasn't always been helpful. Some people have given very scary headline figures that has put people off, and other people have been denying that it's even a problem. Whereas I think the true answer lies somewhere in between. And one of the things that I'll discuss is kind of, as an epidemiologist, what we look out for in studies on long COVID, so that when you come across any literature or when somebody, commentator on Twitter or Facebook describes this, what you can look out for so that you can appraise whether this is a good study and whether you can trust it. So one of the first aspects to look for is the selection bias, and who is in the study? Are the people who they're ascribing to be diagnosed with COVID or long COVID, are they actually representative of all people who were infected, or are they only representative of the confirmed cases? And that can be a problem because the confirmed case is going to be slightly more severe. They probably had this more symptomatic. It was severe enough for them to get a diagnosis. And the initial period in March, April last year, where only very severe patients were getting diagnosed, means that we weren't really getting an accurate figure of what the actual prevalence is in people who are infected, but not always diagnosed. The other thing to look out for is for a control group, so that can control for the background level of symptoms and disease in the population. If people have headaches, people have other conditions, so differentiating long COVID that is attributable to the disease from just background noise can also help to define the scale of the problem. Loss of follow-up, so people who are involved in things like the Zoe app, and that's been an app where you report your symptoms and then people will log their symptoms day to day or week to week, and that has been used to describe how many people have long COVID. Unfortunately, that will mean that the people who are really motivated to talk about long COVID are more likely to stay in the study and continue to report their symptoms, whereas people who have either very mild or no symptoms may lose interest and not report, whereas people with severe symptoms, on the other hand, may not have the energy or the health status able to continue to stay in this study. So that can cause a bit of different difficulty in accurately estimating it. And then you have things like recall bias, where people who know they've been infected may be more likely to report their ailments. So that's just things to look out for. And I think that recent studies have addressed this much better than previous studies. So I think we've got much better evidence now. Next slide, please. So the first study I want to talk about is the Office of National Statistics in the UK and their coronavirus infection study. They conduct swabs, regardless of symptoms, of over 300,000 people to date. And the regardless of symptoms part is very important for meaning that they're not just capturing people who have gone to their doctor, GP, or test site reporting symptoms. It will capture those people who have an asymptomatic infection, which may be milder, and then may give us a better estimate of what the true prevalence is based on infection. And then they match those two. So they match the 21,000 participants of those who tested positive with control participants who tested negative, who were a similar age, similar sex, and who had their swab taken on a similar day, so that you've got a comparative period to compare those to people who may have symptoms from elsewhere. They assessed these symptoms for 4 to 12 weeks after the date of infection, and they covered a wide range of symptoms that may be familiar to people who've had COVID or who are living with long COVID, although they do acknowledge that some of the important symptoms that long COVID people have been missed, so it may underestimate it in that way. Next slide, please. So this is a chart showing the percentage of participants reporting any symptom over time after infection. So this is cut off at the point where the acute part of the illness ends. And you can see that initially just over 20% of participants reported having a symptom at the start of this, whereas at 12 weeks, it was about 1 in 7 participants who tested positive reported any symptom, and about 1 in 50 controls reported any symptom. So you can see that there is quite a stark difference in the number of people reporting any symptom at 12 weeks post-infection. Now, it's important to note that the grey bars around that blue line represent the confidence intervals, so there is a bit of margin for error there, and I think that means that any figure quoting 1 in 7 may not be entirely correct, and it's best perhaps to leave it vague for now, but it does suggest that it's quite a significant number of people who are affected. Now, some of those symptoms will be fairly mild, and hopefully that they won't impact on somebody's life. However, around 60% of the people, so about 1 in 11 people who tested positive in total, reported their symptoms actually limited their activity. And 1 in 40 of the people who tested positive reported that that would limit their activity a lot. So that's the kind of numbers that we're looking at. And it suggests that actually 1 in 40 applied to a large population will be a significant number of people affected in Ireland. And that does give a bit of a warning sign that this perhaps is something to be taken seriously, and we should perhaps move aside from the denial stage of the research. Next slide, please. And unlike the deaths and hospitalizations that tend to be fairly age-related, the association with age doesn't seem as strong for long COVID. So this suggests that perhaps that people of all ages can be affected by this. And it actually seems to be particularly high in working age adults. So the incidence seems particularly high in these between the ages of about 25 to around 69, suggesting that if the vaccination rollout covers just up to 65, that a significant number of people would still be at risk of developing long-term consequences if they're infected. Now, importantly, again, some of these were present in controls, but again, you can see that there are quite stark differences. And even in children, there were differences in the number of people reporting symptoms at 5 weeks. Now, hopefully in children, these would be much milder than in adults, but we have heard stories of children suffering fairly long-term consequences. Now, one of the things that I'd like to highlight, and apologies for the dog, he's just seen the neighbor walking past. This always happens, is that it tends to be the more severe infections that have the symptoms. We've heard that asymptomatic infections can lead to quite long-term consequences. Fortunately, the data in this suggests that most of the long-term consequences were in people who did report symptoms, but that could be a consequence of including quite a broad range of symptoms in the symptom list, and it might not be just limited to people who had a cough, a fever, or a loss of taste and smell. But it should reassure people that the asymptomatic infections don't seem to be driving these major long-term consequences. Next slide, please. And hopefully the other dog's gone now, so that might be a bit quieter for you. Thank you. So then, just to talk about another high-quality study that was done recently. So this was a study conducted in a Swedish hospital amongst healthcare professionals. And again, to avoid the difficulties around confirmed cases versus people who were infected and asymptomatic, they were able to use antibody testing of the healthcare professionals, and then they're able to compare the levels of long COVID or long-term symptoms between people who had antibodies present at the start of the study and compared to people who didn't have antibodies throughout the whole study. And they repeatedly tested them to make sure that they didn't have antibodies developed. And those that did develop antibodies were excluded because then they could potentially have COVID themselves. Now, this was limited to mild COVID-19, and then they reported symptoms at 8 months of follow-up. So there's a considerable degree of follow-up here. But again, this one's slightly smaller. It was about 320 people who had COVID, and they compared that to about 1,000 people or healthcare professionals who didn't have antibodies detected. Next slide, please. So you can see from this chart, again, this is considering perhaps a more important aspect is the percentage of participants reporting symptoms lasting more than 2 months and the impairment that that had on people's lives. So the darker greenish grey bars represent people who were seropositive, who perhaps had COVID-19, compared to people who were seronegative, who perhaps weren't infected. And you can see quite stark differences in terms of work life, in terms of social life, and in terms of home life between the groups. They don't report confidence intervals, so the statisticians watching may want to know what was going on there, but there do seem to be a bit of a considerable difference there. One of the things I find interesting in this is the loss to follow-up that I described as a potential problem perhaps has meant that some of the people with the most severe symptoms weren't able to report, because the difference between the moderate, the mild looks fairly substantial, but in terms of work life, the people who perhaps had marked impairment of their work life weren't able to continue to attend for the study follow-up visits. So that may have meant that we may be missing out on some of those severer cases there. But again, that remains to be seen. So again, comparing the controls to the long-term symptoms in people with COVID-19, you get about an 8% in having a moderately or markedly disrupted work life compared to only 4% of controls, suggesting that a reasonable proportion of people who were healthcare professionals have had that impact on their work. And then again, at the 8-month period, you'll see about 15% versus 3%, which is roughly equivalent to, the 15% is roughly equivalent to the 1 in 7 that we saw in the ONS survey. And the 3% is similar to that 1 in 50 that we saw in the other survey. So you get fairly consistent results across 2 fairly high quality studies on what the proportion of people who have had any kind of symptom are. Next slide, please. So what's better about these surveys and studies compared to the older research? So the testing methods capture the asymptomatic infections, as we've described. They've used 2 different methods, which is always reassuring to make sure that it's not just because of one method or another. One used antibodies, one used swabbing of more random samples. They've got control groups that control for that background instance, because a few scientists said, oh, but what if it's just because people have headaches generally or because of lockdown? And that doesn't appear to be the case in these studies, at least. And the decent sample size of the ONS is always useful for giving a bit more of a precise estimate. However, just to be on the cautious side, there is still an option that recall bias might slightly overestimate these estimates. Some people may be more likely to report a symptom if they've known they've got a diagnosis, whereas other people who've not had a diagnosis may put off those symptoms and just ascribe it to general life. There could be a degree of loss to follow-up, but the dropout actually within the Haverval study, that Swedish study, was actually bigger in the people who were seronegative, suggesting that if it's just the people without symptoms who aren't continuing, then actually we may be underestimating the illness. But in the ONS, I would suggest that with caution with that. Some symptoms weren't included, and a much broader list of symptoms may reveal more problems. Next slide, please. In terms of hospitalization, some people discuss a difference in long COVID between people who've been hospitalized and people who haven't been hospitalized. Often we limit the discussion to people who haven't, because we tend to suggest that actually a mild infection isn't necessarily always that mild. But again, if people with hospitalized account for a significant number of people and an increasing number of more people every day are hospitalized, unfortunately, and we've still not got to those really low levels where we can stop having to include this. And you'll see that about 1 in 3 people who were hospitalized in England that were included in this study were readmitted within 4 months of follow-up, compared to only about 10% of hospitalized people who were in hospital for other reasons, who were matched based on a range of conditions. And you'll see respiratory disease is particularly high incident excess within the people who have been positive, with about 21% compared to only about 1% of the controls. So this will pose significant challenges to the health service going forward if these numbers are correct. And you'll see things like excess risk of diabetes, cardiovascular disease, and chronic kidney disease. So when we as ISAG discuss that we want people to not be hospitalized with this, and we want to prevent them from getting infected so that the unfortunate few who are hospitalized don't have to go through that. This is one of the reasons, is that it's not just a case of attending a hospital for a day and then you're out and you're fine. This can have lasting impacts, and it's important that we use high quality estimates like this to actually discuss this so that the health services can start planning. Next slide. So I've just got 2 more slides very quickly. So one of the things that we often get asked is this not just the same as all the other post-viral syndromes? And I don't know the importance of that question really, because post-viral syndromes of any type are important, and people going through it after flu should be accounted for. People who are going through it after COVID should be accounted for. But there do appear to be differences between people who have been diagnosed with COVID-19 compared to people who've been diagnosed with flu. So on this chart, the red line will show the incidence of respiratory failure as an example in people who have had COVID-19 compared to people who have had respiratory failure with other respiratory tract infections like flu. And you'll see that the red line is considerably higher than that grey line for flu. Now that the direction of those lines does seem to level out with each other and run parallel to each other after a while, suggesting that it's just the acute phase of the illness is worse, but that is then having that lasting consequences, and that is impacting on people's lives. And there are people who have been diagnosed with respiratory failure many months after their initial diagnosis of COVID-19 and hospitalization. And you get a range of other conditions that suggest that there's an excess risk relative to people who have had other viral infections. Last slide, please. So just to recap on that whistle-stop tour of the evidence, we now have much higher quality evidence to estimate the impact of long-term symptoms following the infection. I think in my mind, I've always had a bit of doubt on any estimate that's been put forward on the long-term symptoms, whereas I think now we can start to give some kind of estimates on the number of people who would be infected following an infection. And I think it's important for the scientific community to acknowledge that the evidence that those studies are all out in the last couple of months. The evidence we have now is much stronger than the evidence that we have had 2 months ago. And I think that's important to acknowledge, that now we can move beyond the denial and start talking about what do we do about this? How do we act to prevent more people getting infected? Because it's not just this simple dichotomy of infected, recovered, or died. It's this continuum of long-term impacts. And this can have a significant impact on people's work life. Our health is our wealth. And if going forward long-term, if we want to protect the economy, we need to protect the health of the individuals who are working and living in our society. And I think that's one of the reasons I've always felt passionate about the zero COVID, was that we want to prevent people suffering the acute illness. We want to prevent people being hospitalized this, we want to save lives, and we also want to stop people having these very long-term conditions that can have quite a meaningful impact on people's lives. And we also want to promote the support and treatment options that are still to be decided, need to be so that people get that they need and don't feel gaslighted by the scientific or medical community. Thank you very much, and apologies if that overran slightly.
Thank you, Andrew. No, I think it was very interesting, and it's very useful like that to kind of see in one place for the first time the collected huge amount of data that these studies have done, because for a long time now we've been hearing about long COVID and people have been sharing personal stories, but it's also important to get some sense of the prevalence, and that's what those big studies do. And there's a good few questions coming in. I'm going to save them for the end, but that you've anticipated some of the questions, people wondering about the prevalence and wondering about asymptomatic cases as well. So we'll get to that. We'll have a good question and answer session. But before we do that, we're going to have one more speaker, who is Dr. Chris Buttanshaw. And he is a retired public health doctor, but has also recently been working in the management contact tracing program in Ireland. And as well as that, has personally experienced long COVID, so can talk to us from several different points of view. Chris, it's great to have you here today, and thank you very much for coming to share your story. Chris, can we hear you there? Can you? Okay. His internet might have just frozen at the wrong moment. We could see him there moving on his screen up until a moment ago. Maybe just then I will move to some of the questions while we wait for Chris to reestablish his connection. So, Andrew, you anticipated some of the questions that came in there, but just to maybe capture again and just emphasize a few points. So somebody asked about the percentage of people who develop long COVID. So you said it's about 1 in 7, give or take a bit, with a bit of uncertainty around that. Is that 1 in 7 then of the diagnosed cases? Was that it?
So 1 in 7 people in that survey, and in both surveys included, reported that they had long-term symptoms. Now that's at about 12 weeks or more, 12 weeks to 8 months. So that's the kind of number of people who have symptoms. Whether each individual would report that they have long COVID, it depends. Some people may have fairly mild symptoms, fortunately. So I think the actual true number of people who would classify themselves as having long COVID will fortunately be a bit lower. And one of the estimates in terms of if it's having a marked impact on people's lives, it might be as low as 1 in 40 or something. It might be a bit lower than that once you account for the background instance. But I mean, I was kind of thinking of this when 1 in 40, even if it was 1 in 100, 1% of people, if you apply that to quite big numbers, is a considerable number of people. And these were both in tended to be in younger populations. So it's not just this, it's the older people who are affected. We don't need to worry about it. We're young, we're fine. And I think that's important to notify on that one. But I struggle to put an exact figure to it because of the uncertainties, because these studies might tend to slightly exaggerate it, but it's still a significant number of people when applied to big numbers.
Thank you. Thanks, Andrew. And I think we have Chris back, so we can pick up where we were about to. So I'll reintroduce you, Chris. So Chris is a public health doctor, a retired public health doctor, recently working in contact tracing in Ireland, and also has personal experience of long COVID. Thank you very much for joining us, Chris.
Yeah, my apologies. I hope it works this time. It just dropped out for some reason completely. Yeah, my main career was in the UK, and I have worked in public health, in management, in academia, retired very happily, and now I'm back and sort of involved. And at the beginning of this whole epidemic, I felt, because I've been healthy all my life, pretty well immune to this whole disease, and watched with interest. I gave up watching the television because I felt like I was going to throw things at it. I got so annoyed at the lack of public health common sense in it. So I remember when the testing was absolutely like gold dust, we kept testing the people who we knew had COVID instead of using the test to learn how to stop COVID and things like that. But it was at a distance. And flattening the curve annoyed the hell out of me, because it was said to be a strategy, but it wasn't a strategy. So it was a strange thing. But it was from a distance. And then on Patrick's Day, I got COVID. I almost certainly picked it up down in West Cork. And I'm going to say a little bit more about the symptoms than I would otherwise, because our first speaker isn't here. I kind of appreciate it's for the seminar that I'm talking about those personal things rather than more widely. So next slide. And yeah, that first slide, by the way, I should have said, I put that graphic on because it's like the great alien that's coming to get us, isn't it? And I'm going to say a lot from a philosophical point of view about COVID. That's the main part of what I'm going to say after, and reflect that with my personal experience. And so it's the way we see it that is actually really important to what COVID, long COVID, is going to do to us. So next slide, sorry. Yeah, I want to say just a little bit. Did I have COVID? Well, I wasn't tested, but I had absolutely classic symptoms, bar perhaps about taste and smell, weren't particularly affected, but I had pretty well everything else you can imagine, including what I can only call an encephalitis, this mental fog that you get, but your brain seems to be there, but not quite working with it. Meningitic headache, inflammation, secretions, fever, fatigue. Sounds awful. It was not that bad. I wasn't that sick. 5 days, pretty rotten, better at the end of a week. Thought that was it. Was really okay for about a month. Then I went cycling in the Wicklow Hills. No problem cycling, go up the hills. Well, I got an electric bike, that helps. But you get up the hills, you still work quite hard on an electric bike. Got home, felt fine. Next morning, it was as if I had the flu. Inflammation, fever, feeling rotten, gastrointestinal disturbance. About 3 days of that, worst on the first day, then better again. Did the same thing about 3 weeks later. Exactly the same thing. Fine doing it, ill, in exactly the same way the next day. Third time it happened, So you think, well, this is long COVID. Can't prove I had COVID, which is the interesting thing about the biases, because I was never tested. Officially, I don't exist in the system as a case. Do I have long COVID? Yeah, I'm quite clear I have a version, but it's just by version, isn't it? I mean, as you've seen from the data that Andrew presented, there are a number of syndromes and things all mixed up in there. But that was kind of my syndrome. And so here I am a year later. Am I sort of cured? Has it gone? No. So yesterday, just preparing this presentation will have been enough to kind of bring me back there. A little bit of fever, headache, perhaps a little bit of cloudiness. But I'm retired and I work half time, so I can cope with that. And I think that might be why in some of the symptoms you saw it was more working age people, because I work half time and I do some other things, but I can set my own pace. When I'm forced to set my pace, sometimes we've been working up to about midnight, I will be ill the next day, almost as if I'd gone on the bike ride. And pathophysiologically, I've no doubt it's an inflammatory process. I've never been to a doctor. I suppose I am one, which is the physician, heal yourself. But for me, everything that I have would say I'm getting some sort of viral release or antigen release that's causing an inflammatory response when I do that. So I'm moderately affected in the sense that it doesn't too much interfere with my life. As I say, if I work full-time, it might well. Do I still have long COVID? Well, recently I got shingles, never had it before in my life. Is that a sequelae? Is it just something that happened? I don't know. Now, when I feel tired, is it long COVID, or is that just to do with it? Or is this secondary long COVID? Because I don't exercise as much as I did. That's perhaps true of us all. Put on a bit of weight. Perhaps I drink a bit more alcohol and so on. So there are lots of other factors going on in there that might also explain why I would have symptoms that I didn't have before. So I think in terms of the epidemiology, in terms of public health, the experiences are not only very varied, they become self-reflexive, and they actually change. And my view of my own illness changes as it evolves over time. And it's that I particularly want to reflect on in the rest of what I'm going to say. Next slide, please. Long COVID is constructed, and as we say, properly by the mainly people who have one of these sort of syndromes, but it's not something that is going to stay the same. What we think of as epidemiologists will change, but much more so in the public perception. You remember I showed you the sort of alien spaceship of the virus that's coming in. People have a view, and it's changing, of what COVID is. And we can look back at post-viral syndromes, at myalgic encephalitis, at all the various hard to define syndromes that have been there, and seen that what we talk about when we use today are not what we would have talked about a year or two ago. So it is a dynamic and moving thing, and when we try and measure it or count it or say what the prevalence is, we're actually going to be measuring different things at different times. Now, to me, and the link to the first picture here is Roland Barthes in this, is that Roland Barthes talked a lot about books that were readerly books or writerly books. And a readerly book was one that you read, and a very scientific test would be a readerly book. You read it again, it would say much the same thing as it said to you the first time. A writerly book would say something different. Having read it once, when you read it the next time, your thinking would have moved on, and you would look at what you were reading in a different way, almost like you were partly the author of the text. The text would be different. That, I think, is the nature of COVID. It is a writerly text. And if you take that on to Jacques Derrida, who's the next photograph on that, what Jacques Derrida was talking about was one of the phrases he used is the slippery of the signifier on the signified. Now, what he meant by that was that long COVID is a signifier. It's a word that tells us about some syndrome that's out there. But as we think about it, as we use the phrase, as we experience life, as we have it or don't have the syndrome, actually what to us is signified by long COVID will change. I'm going to say at the end, in what I think maybe the important things to look at, why that's significant. And the last character you see sitting there is Michel Foucault. And Michel Foucault talked about an episteme, that we see COVID-19 within a way of looking at the world that isn't the same if we've been looking 50 years ago or 200 years ago. We are within a system and we see it in that way. And we live within a society which has a view of the correct behavior. So my not going to my GP about my COVID is a kind of deviance. There is a sort of gaze of society. There is a way you are expected to react if you're ill. And there is a way that politicians are supposed to react when they're told about COVID or long COVID. And there is a way media are supposed to work with it and so on. And those things, if we don't think about them, can be part of the problem of the way we deal with something like COVID. So next slide, please. taking that philosophical theme just forward for one slide further, Kant started a whole stream, and arguably for me it ended in Richard Rorty, of talking about the fact that we think there is a reality and we use words to describe it. Actually, the words are the reality, and that's what I think Kant realized. That since we can only describe words in words, there isn't anything beyond language. And language itself is defining the way we see ourselves, we see long COVID, we see everything in our lives. And it, as I've said earlier, changes. That's very different to the common sense view of people when we're talking about long COVID. They think there is a reality, there is a scientific fact that is not context specific. And the second photograph there that I'm showing you is of Richard Rorty, because he took it to its ultimate conclusion in saying, look, you think it's obvious that what we should do about COVID is grounded in some sort of science. We just get the science right and we'll know what to do. If we could just get better epidemiology, if we can just understand the pathophysiology better, we'll basically crack this. And I think what Rorty's saying is no, it's a human thing. It's in us, it's in language, and it's not that simple. So that's a little bit of a rush through some of the philosophical things that I'm interested in, that I think are central to how well as a society we cope with long COVID, deep COVID overall, or not. Last slide, please. So in the last slide, what I'm saying is, second last slide I've shown here. If you think the things that I'm talking about are a little esoteric and not at the center of the dilemmas and the problems we face, think of Trump, think of Modi, where what they've done, and I think they've both done incredibly wrong things around COVID, they come from their perceptions of the way things are in society, and they come from the support of a populist approach, which says it's obvious, isn't it? We know how the world is, you need to get on and do it. Actually, as societies both here and particularly perhaps in Trump's states, we perhaps have lost the ability to look that maybe 50 years ago, and we talk about when Foucault was alive and so on, people understood better the importance of that. So final slide, please. Sorry, it's come up, is it? Last slide, Ben. Yeah, that's it. Great, thanks. So I've talked a little bit about things, and I want to just sort of say, well, okay, out of that, trying to say something that's a takeaway, something that is actually applicable and useful out of a very quick philosophical gallop through a number of things. And some are directly connected, some not so closely. Well, vaccination. Andrew didn't touch on it, but as a sufferer, the fascinating thing to me is, will vaccination make me sicker or better? And actually, theoretically, there are reasons to think it might do both or neither. Maybe it'll do nothing. And which vaccines might work for long COVID? So we're not even at the beginning of what I think in terms of treating long COVID, the most important intervention that we know of at the moment, vaccination, and which would it make any difference when or which you got, and would you be more, is it likely to help or not? The evidence coming out a little bit anecdotally is it helps. This is primarily long COVID about how people who have it adapt to the environment that they live in. What discipline in healthcare is that? That's occupational therapy. I'm always surprised and disappointed that the role of occupational therapy in terms of a way forward is underestimated. We need leadership. I use the NHS term czars. Without any leadership, but we need that leadership not only in the health service, you need it there, but you need it outside as well. We need to look for the opportunities, because I'm running over a bit, I won't say more about that. But there are, of course, good things that come out of COVID as well, and we often only look at the bad things. We need to have more humility. So there's sort of rather ridiculous throwing things at each other that I can't watch on the telly, that actually some of what I've said might help to mitigate that a bit. And of course, then we need what will be close to everyone's hearts, the longitudinal epidemiology to go with it, and research into the basic disease mechanisms. So I hope that is a slightly left field for most of you take, and it's coming from my own interest in philosophy into why I think the way we look at COVID is also as important as the way we measure it. Thank you.
Thank you, Chris. Yeah, very, very interesting, and definitely the philosophy is an original take for us. But I suppose one way to paraphrase that is sometimes important to have words for things as part of recognizing them and dealing with them. And that's where Andrew as well said that long word that people who are dealing with this have chosen, and that's why we use it. So we have some questions. I'm going to bring in other members of the panel to answer some of these, because I think they've been touched on already by the speakers, so we can get another view from panelists. And one of the questions is from Nessa Childers asking, can long COVID occur in asymptomatic cases? And can it occur potentially in an infection that happens after vaccination? So I'd like to go to Yanir first on this, because I think he has a comment on that. And then I think I might go to some other people at the same point. Yanir, is your microphone on?
Just restate the question. I apologize. Just restate the question.
Oh, sorry. It's long COVID can occur in asymptomatic cases, and if it can occur post-vaccination, in infections to occur post-vaccination.
Yes. So first of all, it can occur post. So the point is that it can occur across the whole spectrum of disease conditions that originally happened. What happens with the vaccination is that we don't yet have data about people, because the vaccines have been around for a short time. And so that we don't have extensive data about what happens afterwards. But what we know is that the breakthrough cases have the same spectrum of conditions. They have
when you say a breakthrough case, you mean the small number of vaccinated people who do get symptoms? Is that what you mean?
Right. So the people who are vaccinated can still be infected and have severe disease. And so the point is that there is a small percentage of people who have been vaccinated who get cases. Now, when we say small percentage, remember, it's still the efficacy is supposed to be about 90 or 95%. So it's about 1 in 10 to maybe 1 in 20 people who have been vaccinated under the same conditions will get infected by the disease anyway. That's what's expected, right? And if we take those cases that have been identified as breakthrough cases, then what we see is that of those cases, roughly the same proportions get severe disease, i.e. are hospitalized, and die, i.e. of about 1%. And so there doesn't seem to be a difference in the behavior of the disease in breakthrough cases than in cases that happen to people who are not vaccinated. And that suggests that we will also see long COVID in those cases, but that data is not yet available because there just hasn't been enough time.
Okay, thanks, Yanir. And also on the point of if somebody is asymptomatic in their initial infection, does that give us any prediction about whether or not they will or will not get long COVID? So I'd like to ask Jerry and then Gabriel Scally this question. So Jerry Killeen.
Yep, thanks, Aoife. Could you just reframe that one a little bit, just again?
So
sorry?
When somebody is asymptomatic, if somebody has had an asymptomatic or an extremely mild infection in the first instance, does that mean that then they are unlikely to have long COVID? Is long COVID something more that happens after a severe case?
I think Andrew kind of touched on that, so maybe that's a better one for Andrew to, because I thought he touched on that quite nicely, and maybe Andrew should answer that one.
I can add maybe a point, which is that
Okay,
People think that in general, the mild cases will not result in long COVID because it seems like they're mild, and that's not the case. There is some difference in that more severe cases have long COVID more than less severe cases. But even asymptomatic cases do develop long COVID. And that's conceptually, that's quite surprising. But it's really been seen across the spectrum of asymptomatic, mild, severe cases that we see long COVID cases occurring across all of those conditions.
Thanks. Okay, so there's also there's a question here. Excuse me, because I'm just getting things in lots of different directions. In terms of does the vaccine help at all somebody suffering from long COVID? Do we know that? Like, if they had long COVID, would the vaccination? I suppose that's asking if it can actually help in the case of the symptoms. Do we know this? Anthony, do you know anything about that, or is that known or unknown?
To my knowledge, it's not known. There isn't an enormous amount. It's a question we're frequently asked for particular subgroups of people. So, for example, there was a question earlier about people of a particular condition where their heart rate rockets when they stand up and their blood pressure falls. We don't know is the very simple answer. So we are probably going to find out. And right now, we've just come to a view, the community has come to a view that if you've had COVID, you should probably get a single dose of vaccine anyway, because the protection seems to be higher with the vaccine than with the actual infection, which is unusual. It's usually the other way around. But how that plays out in terms of long COVID, I don't know, and I don't think anyone knows. The question has been asked, but no one has come up with an answer that I'm aware of. So I think our advice at the moment would be to get vaccinated, but keep an eye on what happens as we go along, as we understand this condition more. In other post-viral fatigue syndromes, and it's not entirely clear that long COVID is the same as other post-viral fatigue syndromes, but in other post-viral fatigue syndromes, there isn't a lot of evidence that being immunized against things is bad for you, has a negative impact. And that may well be true for long COVID as well. But right now, there's a significant level of uncertainty.
So just on that, in terms of with relation to other post-viral syndromes, I might bring you in a moment, but just before that, I wanted to ask maybe Gabriel. So we know very little about long COVID because we're still learning. But in terms of other post-viral syndromes, do we understand what it is causing the syndrome? Is it that there was tissue damage in the initial infection, and so it's not recovered yet? Is there lingering virus? Is it known? Is it something else?
Well, there are a whole range of post-viral syndromes, and it's really very difficult to fit long COVID into any of the existing categories. I think just because of the severity of it, the duration of it, the wide range of symptoms, some of which are almost unique symptoms, really. So it is very difficult to fit it in and to understand why. And I think the causation is probably multiple. The symptoms are multiple, the organ systems affected are multiple, and the causation is probably multiple as well. So it is probably partly an immune response, but it could also be that the virus has actually changed some parts of the body and functions of the body. And one of the things that always worries me, and I have mentioned it before sometimes, is the experience post Spanish flu in the United States, where in the years following the close of the pandemic, a lot of people, or many more people than would be normally expected to, had developed Parkinson's disease and the symptoms of Parkinson's disease. And that was very clearly associated. It was impossible to prove at that time, but very closely associated with having had that particular flu variant, that pandemic flu, and it clearly affected the brain. We know the virus, the COVID virus, affects the brain because some of the symptoms are very typically either affecting nervous system, sort of smell and taste, or the brain fog that people talk about. And we also know there are some similarities between COVID-19 symptomatology and that of other post-viral symptoms that can sometimes result in chronic fatigue syndrome. So we're on a learning curve with this, and it's going to be a long time. I think the important thing is that everywhere that has experienced significant amounts of long COVID, needs to make preparations for dealing with the effects of long COVID and improving our understanding of long COVID. So there needs to be a lot of discussion about what additional resource is going to be needed for health services and what research can be funded so that we can find out some of the answers that you've been asking. For example, this answer about vaccination. Does vaccination help people with long COVID? Is perfect for a really well-organized study. And it's that thinking that we really need to engage in now.
Thank you, Gabriel. I think Tomas Ryan wanted to briefly come in on this question too. We've got a good few other questions to get to as well.
We're only starting to learn what SARS-CoV-2 infection is really doing to the brain. We know this virus directly infects the brain itself. It has a tropism for neurons and for other kinds of brain cells. We also know that it causes, of course, inflammatory responses that in themselves are damaging to the brain. We know very little about this. I was recently giving an undergraduate neuroscience lecture on the topic of the brain and disease, and I thought it would be topical to discuss how COVID-19 affected the brain. And I was alarmed that I could communicate everything in big picture terms in 15 minutes of that 1 hour lecture, because there's really a paucity of scientific investigation on this. One of the reasons for this is because long COVID is long and we will need to be studying it over a very long time in human beings. But the other reason, which not everyone may appreciate, is the difficulty in studying COVID-19 in animal models. So a great deal of what we know about pathology comes from studying it in animal models, such as rats and mice. And the problem is that in the past year, apart from it being very difficult for research scientists to do their work in a socially distanced way, is that the standard variants of the virus causing COVID-19 does not infect mice or rats. And so this has caused limitations in how we can study it in these experimental systems. Now, the exception is some genetically engineered mouse lines, which were previously made to be susceptible to SARS-1. These mice can be infected with SARS-CoV-2, and research on these mouse lines has been happening in certain places throughout the world. But because of the limitations of who can work on this, and because of obviously health and safety concerns for anyone doing the research, it's been proceeding much more slowly than you would expect for any other disease that would be causing this degree of international concern. It's worth noting that the Brazilian variant and the South African variant, they've evolved to infect rodents directly, so that may change how research moves forward. The only reason I bring this up is to point out how little we know about what this is doing to the brain. We know it obviously causes a lack of smell in early time points. It causes brain fog. We've seen early neurological studies that have shown that in severe cases of COVID-19, you're finding an overrepresentation of people with neurological disorders, and that they are exacerbating neurological disorders. But we're only starting to see the human studies that are looking at the overall effect of long COVID on the general population in terms of memory, in terms of attention, in terms of other psychiatric conditions. And I think probably most worryingly, although we have, as far as I know, no data on this, is the effect of COVID-19 on fetal brain development. Because we know that maternal immune inflammation is one of the significant risk factors for autism spectrum disorder and other neuropsychiatric disorders broadly too. We don't know how this is going to play out over the coming years. So I think when you put all this together, what you immediately see is that what we know is worrying, what we don't know is immense at the moment. And as was shown in Dr. Kunzmann's presentation, the virus, for giving you long COVID, doesn't really care about your age. So as we enter this stage in the pandemic, where vaccination is going to be taking care of reducing the extreme consequences of the death rate, although not the entire risk of mortality, of course, we're still exposed to theoretically thousands of deaths in Ireland if we completely let it run rip. And we're also at risk of new variants evolving if we allow the virus population to increase. But the real thing that we need to be conscious about is that if we go through a stage where most of the population are vaccinated, and by most I mean around 50%, and then we allow the virus to run riot in Ireland, what will happen is we will get a huge long COVID morbidity consequence that will be borne out over a period of years. We just don't know what that's going to look like. But what we do know, I think, is that it will not be worth a premature reopening of a few months when we could have simply waited until everyone who could be vaccinated was vaccinated and that we got cases down. We can eliminate this risk. It is a choice.
Thank you, Tomas. So I think that's a very important point. Your last point there that, a hasty reopening now could be devastating for a huge number of people. And we make a mistake when we're only counting the toll of this pandemic in deaths and not looking at the other impacts as well. So I have a question here that I think maybe our guest, Chris, might be able to give his perspective on, because it's also talking about some of the how this is dealt with in other countries, and maybe also one of our other panelists as well. So this question comes from Rita Boyle, and she's saying, as an Irish person abroad, I see a difference in management of long COVID. I attend a multidisciplinary long COVID clinic. I have access to senior researchers, such as the head of neurology in one of the top hospitals in this country. I'm not sure what country this person is in, actually. The same hospital is currently setting up a pediatric long COVID clinic for children. Will Ireland do the same? This hospital takes the approach that patients know an equivalent amount or more than the treating physicians. This dramatically shifts the relationship, and the feeling of being heard and understood is massively supportive while we wait for treatments to be discovered and approved. And how are long COVID cases being counted? And is Ireland going to learn from any of these other experiences? So, Chris, perhaps you could talk, because as you said, you spent most of your professional life in the UK. You could give us maybe a different perspective on what's happening in other countries.
I can't tell you too much of the facts of what's going on there. I think that the point is we're not counting long COVID at the moment. We have an awful lot of the building blocks in place to count long COVID, but we are not building the little bit on top that we need to actually count it. So I think we need that. One of the points that I was making, and I think everybody is making, is that it's not one syndrome. It's a whole range of things that come together. And there are people who have, I think, sometimes very, very specific problems. And then you have people who have very broad problems. I agree absolutely with the questioner's thing that involving patients, and that was the point about occupational therapy, involving patient in their experiences of it and driving it by that. I don't think there is a one size fits all. I think all countries are at a very, very early stage in finding solutions. What I think we often fail to do or what we try and do maybe is put in a solution and then make it work around patients. And my suggestion is what we're missing is the leadership. We need to identify the leadership, and that needs to be within the health service and without, and needs to be leadership from people who have the syndrome as well as those who are responding, and let them respond to what is in essence a complex problem, a problem that needs an adaptive response, not a big plan and that's what we're going to do. So I can't answer it specifically, but in principle I think that's what we should be up to.
Thank you, Chris. So I'm going to add in a bit more here, and then I'm going to ask more people because this other question links in with this one. So this one's from Sheila Gallagher, and she says she's personally been living with long COVID for a year. She has headaches, mental health issues, burning in lungs, heart palpitations, a list of symptoms, but that feels that doctors don't take her seriously. They think she's making them up. She's wondering if there any advice we could give in terms of where to find help on this, anywhere in Ireland that people can go for help with this. And do we have anything like this? So I think this links in with the previous question because they described a very different scenario where they were really being listened to. So I think maybe Jerry and Gabriel might come in on this, and then we're going to talk a bit more about, after that we'll talk a bit more about the cases in schools and the possibilities there for what we've seen. So Jerry, would you be able to address this?
Sure. I think, most of the diseases that I've worked with and a few that I've had have long-term effects, and they're primarily chronic diseases. Now, I'm lucky enough that the two chronic parasitic infections I've had, they're both treatable. And so what you learn the hard way is just how much these things take out of you that you don't perceive yourself, because particularly in working age people, because we all brush stuff off. We say, I'm grand. It becomes your new normal. And, my wife and I, we thought we'd aged suddenly overnight, and we carried around chronic schisto for a year or two before Polly was finally diagnosed. And then I knew what was wrong with me. We were both treated. And it's like you get your youth back again. We thought, it was becoming kind of family age and kids and all that kind of stuff. But no, you get this huge amount of energy back. But the difference, of course, with COVID is that there's no drug that can magically take away that chronic illness overnight, as we experienced. And then regarding the question from Sheila and from Rita, I've had a number of friends and colleagues who've been hit by fairly severe long COVID. And what's interesting is that they were all told they were fine, and they were all, and two of them come from really tough backgrounds. Pierre Pio is an Ebola specialist. He's been through many Ebola outbreaks, and it was COVID that got him, and that's the way he phrases it. And then you got somebody like Paul Garner, who was lived in Papua New Guinea for a long time, and if you really want to get something nasty and unpleasant, that's a great place to go. And that didn't bother him, but long COVID has really taken one of the world's leading evidence-based medicine specialists largely out of action for the last year. And at one stage, Paul wasn't sure if he'd ever work again. So, they're not the kind of people who make these things up. It's very easy. It's very difficult for the physician to be sure. It's very difficult for the patient to be sure. And I just advise people to be aware of the risks to both the patient and the physician, and Chris would be both, of dismissing things, particularly when they're low grade, but can account for huge amounts of disease burden. Like we reckon the chronic malaria, for example, wipes about 2% off the GDP growth of the countries that it affects. That's a very big amount of productivity gone on the basis of symptoms that you could easily dismiss as being things that you're familiar with.
Yeah, optimizing health and optimizing the economy seem to be the same thing. We're learning that the hard way. Gabriel, do you want to come in quickly on this question?
Yes, I do. I have often said that one of the things medical school did for me was, and set out to do for me, was to teach me lots of different ways of saying I don't know without ever saying I don't know. And I think a lot of doctors, when they're confronted with a difficult question like, well, what can you do to help me with my long COVID symptoms, will just sort of freeze and not know what to do. In order to know what to do, we actually do need two things. We need more research and more literature, and we need better access for people to that so that they can learn about their own symptoms and their own problems and become expert patients. I think that's really important, and this is a good opportunity to do that, and it's a good opportunity for professionals to help people understand the literature, understand what it is. The second thing is we actually do need some investment in Ireland in this. In the UK, the NHS in England set aside £10 million last November to set up a series of 10 clinics across the UK, bringing together doctors, nurses, therapists of varied disciplines and investigatory facilities in order to respond to this problem. And we do need that sort of organized program, as I was saying earlier, of response to long COVID, specifically responding to long COVID. And it's going to be difficult, and it's going to need more resources, because there's a huge backlog of work that the health service has to undertake, but we can't ignore the problem of long COVID. So it does require, it requires some action for long COVID, specifically a program on long COVID.
Yeah, so this is something that we're sorely lacking in Ireland, it seems. But for Sheila, who asked the question, I suppose Claire Toomey, who wasn't able to attend today, she does have, it's a patient group, but they are providing support to each other for people suffering with long COVID. So maybe that is one place that you might look. So it's called COVID Cases Ireland. So time is ticking on. We want to wrap up soon, but there are a few things we just want to do before we go. And one is just to get back to the ideas we saw in the data presentation at the beginning, where we heard about the high number of cases in school-age children. And this links in with the possibility of long COVID, of course, in this age group. And this is where I'd like to bring in Olive O'Connor, who has been looking at the school situation and has talked previously about experience of a post-swine flu syndrome in her family. So maybe, Olive, if you could talk a little bit about that. And then after that, I'd like to bring in Yenir.
Yeah, thanks a million. I suppose just by way of background, in 2009, my daughters contracted swine flu H1N1, and they became very sick. They were very sick with the virus, but afterwards, the long-term impact on two of my girls, basically one of them in particular, she couldn't walk, she couldn't get dressed, she couldn't think straight. She was having heart palpitations. It took her 3 years to get a diagnosis, which eventually basically had triggered juvenile arthritis in her. For all of that time, it was post-viral, but they wouldn't actually tell us anything about it. They contracted that in schools. Schools weren't closed during the swine flu pandemic, but our cases ended up closing the school at that time. And I suppose from that, I'm always thinking about prevention is better than cure. And the impact of Nicole not getting diagnosed or not getting access to services, and my other girl as well, I suppose, is the fact that they had to have multiple MRI scans, multiple blood tests, multiple everything, which impacts the system, primary and acute, impacts her. The other impact of not having a diagnosis, which brings us to the name of long COVID, I suppose, is if you don't have a diagnosis, you can't get a medical card. Then for a parent who may need to take time off work or be a carer, they can't access carers leave. So it's really important that we do not just, I suppose, try and get them services or access to treatment, but we actually need to look at this from a systemic point of view. In relation to schools right now, and I've been working on this since last August, currently the mitigations in Irish schools aren't in line with international best practice. We don't have proper ventilation in our schools. We're not monitoring it correctly. We don't have masks in primary schools. And this puts children at risk, and obviously school staff. And we need to always look at prevention being better than cure. I suppose we're looking at children not being vaccinated yet, or school staff, many of them either. So this is a big kind of risk. And if we were to look at data, I suppose, under the ages of 25, in Ireland, we've had over 60,000 cases of COVID-19 in young people under the age of 25, which is about 30% of our population. And it changes ultimately. Over 800 of those are hospitalised. If we were to talk about what Andrew said, just looking at 1% of those getting long COVID, that's a lot of people that could potentially have long COVID. And we really, really need to be thinking about that in terms of the numbers of people. And also individually, as Chris said, we need to think about the human aspect of that. My daughter was told twice by two different healthcare professionals it was in her head. She was ultimately told there was nothing wrong with her. That devastated her from a mental impact. So then she had to go to psychology services. So we really, really need to listen to patients and people. In our schools at the moment, we don't have very good data in relation to the way it's being collated. You can estimate in and around over 1,300 cases in schools since they reopened last year, but we don't have a definitive figure on that. We're lower on testing as well. So we need to, I suppose, up the game. If we really want to find out how many children are getting COVID in school, we need to increase our testing and, you know, actually do what other countries are doing better. So I suppose for me to kind of summate where we're at right now, we need to look at the impact on the person, on the family that might be looking after that person, on their impact on work, health systems and our economy. So it's prevention is better than cure for me.
Thank you, Olive. Yeah, and I think, you know, even as you mentioned there in terms of the mitigating practices in schools, it looks to me like school principals were slightly left, you know, just set off, cut adrift and left to figure it out by themselves. We're not given clear instructions on what are the steps they could take with regard to improving ventilation. And the time that the schools were closed looked to me like it was sufficient to do good surveys of the ventilation in schools. And perhaps teachers and principals could have been told, you know, these rooms are just no good in this context. These rooms are fine. And, you know, set up a tent in your football pitch if you have one, you know, marquee tent or something to replace but the missing classrooms. But these steps weren't taken. And the idea that suddenly the principals have to become ventilation experts on top of everything else is kind of ludicrous. Yanir, I think you wanted to come in on this point as well. Before we wrap up for the day.
I think we need to really focus on the basics here, thinking about the cases in schools going up. Depending upon what you measure between, and this is for asymptomatic, mild, and symptomatic cases. So children are often asymptomatic, so people think they're not sick. But if we're talking about long COVID, somewhere between, let's say 10 and 30% from severe disability to mild disability are going to happen in children who become infected. And now you have to ask, how long is this going to affect them? And the answer, the best we know is that from SARS, which is the most similar disease, 10, 15 years after originally being infected, people are severely disabled. So when we think of the consequences for lives of children, we have to think about what are the severity of their cases. Again, even the mild long COVID is a disability that people will carry with them for many years potentially. That's something to be aware of. And the other part of this, and let me say this in a particular way, from the beginning of this pandemic, people have talked about how somehow, I don't understand why, that those who have prior conditions, their lives are somehow not of value. And if they die, there is no big deal somehow. Now we have a huge population of people, including some 10 to 30% of people, of children, who are going to have prior conditions. And what do we have now to say about the quality of their lives and the fact that by inaction, we have allowed them to become sick and to develop this reduced life quality potentially for the rest of their lives.
Yeah, that's terribly sad, and it doesn't really bear thinking about, but it's something that we have to take serious steps to avoid, of course. So before we wrap up, I'd just like to ask our guest Chris, if he wants to say any last words, any message you think that should be taken from this, and maybe the same to Andrew.
It's been fascinating to listen. I think the main message to me is take away is the complexity of it, and it's the way you can bring together I agree with the point last being made, that I think that the long COVID and the way it is handled and managed is really important to getting support for proper ways of managing, if you want to call it short COVID overall. I think it's a very powerful tool to produce a better response to the epidemic overall.
Thank you, Chris. And Andrew?
Well, it's really interesting to hear all the people's experiences, and it was a shame we couldn't hear more from Claire's, because I think most of the audience could probably knows 100 times more about this than I do. I just look at the data, try to give an honest account of that data, but I think it's that we need to start believing people when they say that something's wrong. It's rare that people do that for no reason, And the data is now stronger than ever that this is real and it is meaningful. The exact figures we don't yet know, and I wouldn't want to put a figure on it. It can be complex, but it is time that the evidence is shifted towards that balance where, as an epidemiologist, I would be comfortable with saying, yes, this evidence is strong enough to support that this is happening and we need to be taking it seriously. And prevention is better than cure where possible, but we still need to make sure that people who are going through it get the support that they need.
Sorry about the background noise there. So I think we're going to finish up there, but I do want to just say before we finish, so all of this, I suppose it puts, thinking about long COVID, puts the situation we're in and the efforts to get the cases right down in a new context. And I think there has been a tendency only to count in terms of deaths, and that's a mistake. It's ignoring a lot of the suffering that's going on. And as Andrew said there so clearly, we do need to listen to people when they tell us what's happening and listen to them. But I was just wondering, Anthony, as we wrap up now, could you just make a comment on the relevance of the idea of elimination or zero COVID or aggressive suppression in this context, and what it means in the context of long COVID, but also in the context as our government is talking about a gradual reopening again?
I thought the first thing is it's likely that the major cost of COVID will be long COVID. That the cost, if you do the sums, do the basic economics, something that affects maybe 10% of people for potentially years is going to dominate the costs of most illnesses. We don't know that yet, but it's very likely. The objective of strong suppression, which Taoiseach has repeatedly called for, is to reduce the number of cases as fast as possible. And there is 3 benefits to that. One is it reduces people getting sick and dying now, which is a good thing in itself. The second is it reduces the risk of long COVID because there's fewer cases around. And thirdly, it gives us more options for doing stuff. It gives us more options for public health responses. It gives us more options for getting the vaccination out and done. And it gives us more options for changing how the government is seeking to control COVID at the time. But it's not going to happen by magic. It's not going to happen just because we want it to happen. It's going to happen because we make a decision that that is what we want. And if we don't, my concern would be that we could end up with, even at the current number of cases dragging on for 3 or 4 months, that's an awful lot of sick people. That's an awful lot of long COVID. It's an awful lot of admissions. Unfortunately, it's an awful lot of deaths. And all of that, not all of that, but much of that is avoidable. But it's only avoidable by decisive public health action now.
Thank you, Anthony. Yeah, and I think that's a good place to wrap up for the day. So we've been an hour and a half, but this was a big topic, and I think it was very important to hear a lot of different perspectives. So, as you know, long COVID hasn't received a lot of attention. I think many of the people who are suffering with this, as we have heard, have feel quite isolated and ignored and not believed. And that's something that needs to change for many, many reasons. And that's something that we need to look at. But we also need to think about where we are now in this pandemic and what we can do. And I think one thing we should take from the vaccines, the availability of the vaccines is wonderful. They are really helping. We can see that in the case numbers, the people who have received the vaccines, the groups that have received the vaccines, the numbers are coming down, and that's really positive. And this makes the possibility of zero COVID even more achievable, I think. And this is where, Israel is perhaps a good example that they may achieve zero COVID with the combination of the lockdown and the restrictions and the vaccine program. And they might be an example then for the rest of us, hopefully. And we do need to be very cautious as we proceed. We have seen that there are some worrying signs in some of in the data, and we can't make the same mistakes again. We all want to open up. Everybody wants to open up. We want to open up safely and permanently. So it's a matter of getting that right. So careful steps to be taken as we move forward. And if we can get our numbers right down, if we can get the cases to this manageable level by public health doctors, and the vaccination program to get them down even further, we can achieve zero COVID. We can put this behind us, and we can start thinking about this more in the past tense, hopefully. So thank you to everybody who participated today and to everybody who listened. It was a bit long, so thank you for staying with us, but a very important topic and very interesting contributions from our two guests, Chris Buttanshaw and Andrew Kunzmann. So thank you so much for everybody's contribution today. Thank you.